title of our session is Empowerment Through Numbers, Social Media and Technology. I think it goes much more beyond the numbers in being able to hear that the patient's experiences, to build those communities, to be able to leverage social media and how medical practitioners use that and how that can feed back into industry in a good way. Joe, I'm going to go ahead and start with you. You've obviously spent a lot of time in this space, in patient communities. Talk a little bit about your experience in that space and some of the messages that many of those that come from industry and how we use patient centricity and experience and engagement maybe need to look about that a little bit differently.
So patients that are members of those communities will never use the term patient engagement, but they will use all the time the term engaged patients. And it's an issue of perspective. If you speak of patient engagement, it's still something done to the patients. Well, if you speak of engaged patients, people get engaged on their own, and they see almost all the time that being engaged really transforms the quality of care that they receive. And just participating in those communities teach people that they have to become just an equal partner in the care, be totally involved in shared decision making, and that no one else can do it for them. Maybe their caregiver, but no one else can do it for them. They also understand that most of care is self-care. 99.9% of the time, when you're a patient, you still need care, but it's outside of the medical system. And so those online communities make a huge difference and help them really look at their life in their cancer continuum in a very different way.
So how is it different today in the power of the patient in those communities than it was even 5 or 10 years ago?
So I started ACOR in '95 when the internet was probably millions of times smaller than it is today. And what we were doing, I was told for the first 3 years that it was either a criminal activity or super dangerous and that we were going to kill lots of patients. And so far, I know that there are about 400,000 people that die of medical errors every year, and we have never seen one patient dying of information. So I'm still not convinced that it's that bad. At the time, we were using very simple technology. We were using only listservs. And it's never about the technology. It's all about the conversation. As soon as you provide people the ability to communicate with one another, you create some magic. When we started, PubMed did not exist. People didn't have easy access to all the abstracts. And all of a sudden, 3 years after we started, PubMed was open to the public, and that transformed completely the kind of conversation people are able to have. So in properly run communities, if somebody comes and tries to sell you some crazy idea or some products, it will take, the community are self-monitor, self-moderated, and you can be sure that someone is going to come very fast and say, what you're saying is interesting, can you please provide some scientific reference? And it's the most efficient way to make sure that the quality of the conversation remains really high. What's happening today in the conversation, because people have access to all this scientific data, and the fact that you have a population, at least in the US, population of super educated people, and those super educated people become cancer patients, they apply their previous expertise in becoming super informed patients, and they educate the thousands of other patients that are in their communities. So all this conversation about the immunotherapy have been going on in our communities for years. And many of the patients are aware of the results of early trials years before it gets published in peer-reviewed publication. I'm currently following some conversation about the use of Keytruda for sarcoma patients, and I'm sure that nothing is going to be published for 2-3 years. And the people are reporting what's happening in their trial almost on a daily basis. Big changes.
So staying within that theme of big changes, Greg, you've also been working in this online network space, and particularly working with medical professionals. Talk to us a little bit of how doctors and other practitioners use social media. What do they follow? What do they use? How does it impact the way that they actually treat patients? Talk a little bit about that experience.
Sure. So I think to start with, it's probably fair to say that when I started studying online communications about health about 10 years ago, the conventional wisdom was that, number one, people would never talk about their personal health in social media because it's way too private, and that physicians would never use social media because there was no incentive for them to do so. There are high risks of privacy violations and so forth. And so nobody was more surprised than I was to find that doctors were some of the earliest adopters of public social media channels like blogs and Twitter and eventually Facebook, and certainly some YouTube doctors as well. But what I've found through talking to literally thousands of doctors over those 10 years and studying the things that they're doing and saying and the way that they're interacting online, the thing that I found that's the most consistent theme among them is that they are the doctors who always want to know about the best way to practice medicine and the best way to practice medicine for their patients. They're doctors that tend to go online. You know, maybe they start out going on to refute bad science. I can't tell you how many online physicians we owe to Jenny McCarthy and Donald Trump talking about vaccines and autism. Literally, hundreds of doctors have said, that's why I went online, because I get tired of my patients getting sucked into this nonsense. And we still see that as a role being played today. Physicians are calling out the media for practicing bad science. But mostly, and Gilles touched on this briefly, those online communities can be a tremendous filter for sort of the opposite kind of problem than he was seeing 20 years ago, which is that we have so much information that finding the information that's actually really good and valuable can be really difficult. And so the physicians I've talked to, many of them use social media almost exclusively as a filter for good information because they're engaged in the communities and connected with the people who they know are going to provide that good and trusted information.
So elaborate a little bit more the dynamic, particularly between the physicians and patients and that dialogue that occurs, because actually it's a bit more dynamic than people would actually think about.
Yeah, and this was another really kind of surprising thing. We've been tracking online conversations since 2009, and actually I just posted on our blog about this today, but we looked back at lung cancer conversations, for example, going back to 2009. And what we were seeing is that early on, 2009, 2010, we were seeing the kind of behavior that maybe we would all expect to see, which is that patients are talking to patients with some caregivers and advocacy organizations mixed in. Doctors are talking to doctors with some medical societies participating. But what we've seen is a huge fusion of those online communications, such that patients have learned, our patients are so sophisticated now that they're actually able to learn from doctors. You know, but a lot of people maybe don't even believe that patients would want to go find the latest medical study, but guess what? They do. The patients who are engaged want that. And the doctors who are really interested in practicing the best possible medicine are understanding the experience of living with a disease or a condition that they could never see from seeing patients in their office or even reading a study, because they're getting that 99% perspective that says, here's what I as a patient am doing when I'm not in the doctor's office.
So maybe that's a good transition to your experience, Dr. Roy, of taking and leveraging the technology that exists and reaching underserved populations with the treatments that they need. Maybe you can discuss a little bit about Project ECHO and your experience there for the audience to understand that, and then we can flesh out some of the learnings that you've gathered through that process.
Yeah, so the mission of ECHO, which stands for Extension for Community Health Outcomes, is to democratize medical knowledge and get best practice care to underserved people all over the world. We are making a very big push in the cancer arena now because fundamentally we see when we look at the moonshot we see so much investment in innovation, but not a commensurate investment in bringing these innovations to the last mile of healthcare to reduce disparities. We have estimated that there are 6 billion people in the world who don't have access to the right knowledge at the right place at the right time. So they can't get the right care at the right place at the right time. And millions of people die because of that lack of knowledge, because they're sort of trapped as monopolistic ways in the heads of super specialists that reside in academic centers all over the world. So we have a goal to improve the lives of 1 billion people by 2025. I invite all of you to join us. The project started in 2003 to tackle one healthcare problem, hepatitis C. There are 170 million people worldwide who have it. It's a curable disease, totally curable, but only 2% of the world's population has been cured because people don't have access to the knowledge of the treatment. And so I was having this problem in New Mexico, where I work at the University of New Mexico, and there was an 8-month wait to see me. People were driving hundreds of miles each way while they were getting a chemotherapy-like regimen with interferon and making 12 trips for one course of treatment. And so if they were poor, they couldn't get it. And of the 28,000 patients that had already been diagnosed, only 5% or less had been treated. So we developed ECHO with the goal to bring hepatitis C treatment, chemotherapy to all patients in New Mexico. And then we knew if we could do that, we'd have a model for complex diseases like other cancers, prevention of cancer, screening for cancer, linkage to care, precision medicine, survivorship, and palliation to really democratize that knowledge. But for the hepatitis C, what we did was ECHO is based on 4 key ideas. We used technology to leverage the expertise of a multidisciplinary team, which was a liver specialist like me, a psychiatrist, and a pharmacist. Second principle is to share best practices. So we set up 21 centers of excellence for treating hepatitis C in New Mexico, 16 in rural areas and 5 in the prisons, each of them run by a family doctor or a nurse practitioner. And that brought us to the third principle is how do we make a family physician as good as a multidisciplinary team at an academic center? And we said we would train them the same way. When I was doing my fellowship in Boston here, I would see a patient present to my professor, see my patient present to my professor, and ultimately I went from novice to expert. And I said we would do the same with these 21 centers. So they became experts, and we would track outcomes. So the heart of ECHO is something called a tele-ECHO clinic. It's a knowledge network. All 21 of these rural clinics join us on an interactive video network like Hollywood Squares. And one by one, they present patients of hepatitis C to our team. And we help them. And we keep doing it again and again and again. And they learn from each other. They learn from us. But mostly they learn by doing. I always like to ask this question. How many of you, and I'm going to ask this right now, in the audience have taught your son or daughter to drive a car? Okay, and if I told you you would have to just give them lectures on how to drive a car and then give them the keys to the car, how would you feel about that? So that's the problem in medicine too. There's so much innovation going on. We are expecting these primary care doctors to just adopt it and use it, whether it be for prevention or palliation or survivorship, and it's not going to happen. So they have to learn by doing under what we call iterative guided practice. And as we started doing this week after week, the wait in my clinic fell from 8 months to 2 weeks over a year and a half. And we then showed that provider satisfaction, provider isolation went down, satisfaction went up. And lastly, we published in the New England Journal of Medicine a head-to-head study showing these rural clinicians and prison doctors could produce the same level of care as the university. As we've expanded this project, we first started with hepatitis C. Now we do it for 22 different disease areas in New Mexico, for rheumatology, for HIV. We've also expanded it within the United States to 30 universities. We have 70 hubs in the United States, in the VA, other universities for almost 50 disease areas, and we're in 16 countries. But the main application that I see in cancer is this. Even today, 50% of the US citizens are not getting appropriate screening and prevention for colon cancer. No science is going to change that unless we can bring the knowledge of how to do this and make it happen in rural areas. And worldwide, this also we know that in African American citizens of the United States, breast cancer rates breast cancer is diagnosed late and they die more often. We know that more than 6 billion people in the world don't have access to survivorship services after their cancer is treated. So those are the kinds of problems. Palliative care is another one. We have palliative care echoes out of MD Anderson, out of Northern Ireland, out of multiple other programs around the world. And we are embarking on a program to bring echo into the cancer world in all these different areas, all the way from prevention, screening, linkage to care, helping oncologists with more specialized treatments, precision medicine, survivorship, and palliative care.
So building upon this idea of being able to provide or democratize access and minimize the variation of care and the experience you've had in this model, what are the keys to success in being able to scale it a bit more, and particularly within the cancer space and particularly within the US?
I think that the key to success is a system which has value-based care rather than fee-for-service. Because in a fee-for-service model, all the incentives are for me to monopolize the knowledge myself. And so if I'm a cancer center, all care should come to me, because then I can treat all the patients, I can do all the testing, I can do the PET scans, the MRI scans, deliver the chemotherapy, offer the survivorship services, and the palliative care if needed. The problem with this approach is that a very small minority of the US population can actually come to Sloan Kettering or MD Anderson or Dana-Farber or whatever. And so, but in a value-based system where you're responsible for the best health for a population, where we are interested in access and patient experience and best outcomes. Best outcomes can often be in prevention. So I'm going to ask this question to this audience here, guys. How many of you would like to prevent your cancer or get best practice treatment for cancer? How many of you want health or you want health care? Is there anyone here who wants health care, or do you want health, right? So I think that the challenge here for us is designing the system based on value to the customer. An engaged patient wants health. He doesn't want health care. And so reconfiguring this system so the right knowledge is available at the right place at the right time to get the right care needs democratization of knowledge. And you need incentive systems that are based on value. And what is value? Not what's valuable to the academic medical center, but what is valuable to the patient. And I just mentioned I just asked people what was valuable to these people, and they all value health.
Well, in that conversation, and we've used the term value many times today, it tends to depend on who is that perspective. In your experience, as you talk and interact with patients that have built their voice over time, what do they most want? What are they most lacking?
So I think that what they would care the least about is having a conversation about value-based medicine versus, it's of absolutely no concern to them. What's of concern to them is making sure that they get the best care for themselves and that they have as much a voice as possible. They can't always have like a full voice, but they have to feel really good about where they are now and feel good about the decisions that are going to be made about them. One of the best way of doing this is what the system, whatever system you decide, will never do, which is to help them navigate the system. The healthcare system in the US is so complicated that probably the only way an individual can navigate it is by getting support from other patients that have been there or that are there right now, asking questions, receiving answers, and will never be a website from any company or any government that is going to help them do this. This has to come from other people that are in the system that have the same experience. And the breadth of the experience is so big that you can, if you're an individual and you want an answer, it can only come from the network.
So in coming from the network, Greg, and you work a lot with industry, and there's a lot of interest on the intelligence, data and qualitative, that comes from these networks, and capturing those perspective into actionable insights. Talk about your conversations from those that come from industry. What has worked, what has caught people's attention, and some of that resistance to that information.
Sure. First of all, I want to kind of give a shout out to Kathy Euste, who earlier today was asked about what the goal was for the Multiple Myeloma Research Foundation. And I'm going to paraphrase her probably badly, but what she said is that she wants to have a world where for every experience that a multiple myeloma patient has, they know what needs to happen next and where they're going to get their information and what is going to follow, because that community has been so proactive in aggregating the data, not only about their treatment, but about their experience in general. And I think that's really important to call out. So this is a roundabout way of answering your question from industry's perspective. I think the companies that I work with, what I generally wind up telling them is in social media and in patient communities, and frankly, even in physician communities, there's a lot of value to be offered by industry. There's a lot of knowledge there that could be tremendously valuable for those communities. But what's really necessary for the manufacturers or the healthcare providers, the hospitals, is to think about, to actually study what is it that community needs and values. And is there a way, within my strategic framework that I can provide that thing that they value? It's not the way healthcare companies are really set up to think historically. They're set up to think about, I have a point of view, I have a strategy, I'm going to execute against that strategy, and I may tart it up a little bit to make it look patient-centric, but I think we all know patients can see through that stuff like nobody else. And so being able to navigate some of that cultural change inside large, fairly hierarchical healthcare organizations is maybe the toughest thing to do in my experience, to really facilitate that organizational change, to overcome some of those barriers and some of those inclinations toward risk management versus adding value. That's a tough shift, and understandably so.
In my guess, this resistance to change, I don't want to put words in your mouth, Dr. Orr, but my guess is that was one of the challenges that you faced as you go out and you work with those family practitioners and you're asking them to behave differently than they have in the past. How did you get over maybe some of that resistance that you faced, or maybe there was a lot of receptiveness that you faced with the physicians or the communities and the like to be able to drive forward, in this case, Project ECHO?
The general value proposition for us, for a primary care clinician, is this, that look, you're a generalist and you're doing everything. And with the current pace of knowledge explosion, which is logarithmic, it's really difficult for a primary care doctor to actually offer best practice care for heart failure, for cancer prevention, for rheumatoid arthritis, for systemic lupus, hepatitis C, neurology, and everything else at the same time. It's hard. So what we're saying is, but this lack of knowledge is translating into a lot of patient suffering because people can't access the right specialist. They don't know where to go. They can't navigate the system. So if we can move the knowledge to you and you choose an area of interest, it could be cancer prevention, it could be survivorship. Out of the University of Chicago, we have a program in breast cancer survivorship where they train family doctors to be survivorship experts. So that now you first take care of your own patients who are breast cancer survivors, then you take care of the breast cancer survivors of the 3 other partners in your practice, but then you also accept these referrals from your community because there is no survivorship expert within 100 miles in either direction. But your patients who received all this chemo and all this radiation now need some help. And so they accept this as a specialty that they're developing. And in return, we give them once a week mentoring until they become experts, and then less often. And another one chooses cancer prevention. That is, they may run smoking cessation programs. They may run HPV vaccination. So they are becoming experts. That's the value proposition for them. And all over the world, we have a tremendous reception from people. That's why we have 94 hubs in the world for 16 countries. But another 250 university kind organizations have already signed collaborative agreements with us to replicate the model. And we've partnered with the US government for HIV control in Namibia and elimination of hepatitis C in Georgia. So the idea is the same, that getting the knowledge to them and convincing them, they get it very quickly. There are 40 publications on ECHO right now showing that it produces joy of work for primary care clinicians. And it helps people stay in rural areas, recruitment and retention, and it helps them learn more. They like to be a part of a community of practice. Living in a small town without specialty support is very isolating, because you have these patients you really want to help and you don't have the knowledge to do it. So it serves that need too.
One additional point, Jill, that you and I were talking about before is there is a movement with its benefits to generate data, to lead to actionable insights. But there is some knowledge that you simply can't quantify, that you lose the nuance of the patient experience, whatever you think is the proper term here. I don't want to use the wrong term. Talk about that two-way dialogue that's important as industry goes in and wants to leverage these networks to provide however value that community sees and needs. Talk about that aspect of that two-way dialogue.
Sure. Before I do this, can I make one mention about expertise?
Sure.
And so cancer patients learn that as we enter this world of precision medicine, it's not enough to go to see an oncologist. If you have a leiomyosarcoma, it's not enough to go to see a sarcoma specialist. You need to go to see a doctor that is specialized in your subtype of disease. And to find this information, once again, only the network of patients is able to help you find the 2 or 3 doctors that are really specialized in the country. Of course, there's a huge, there is always this tension between the major cancer centers where you will find most of those great specialists and the fact that many people are receiving care in a community cancer center. And that tension, I think, is going to take some regulation to try to rebalance it. As far as the conversation, many companies have been started the last few years to deal with big data. Many companies also have been started to build online communities so that they can collect data, aggregate it, and sell it to customers. We look at it in a really different way. We think that there is that really the patients are the most underutilized resource of the healthcare system. And what you can collect from patients, which has the richest value, is not data, it's the knowledge they have in their heads. And the only way you can collect this data, use it, is by making them partners, having a conversation with them, just as they're having conversation between each other. And if you use transparency and let people know that we offer you this community, we are also a for-profit company, and we're working with people in industry or health systems, and they need to learn from you. Therefore, we're going to ask you some questions that are going to go back to our customers. The patients are delighted to provide the expertise that they have that no one ever asked them about. And it's transformative. The people love being able to share with others what was completely under the radar until now.
Before we get into the questions, and for those that want to ask their question via the app, please go ahead and do so. You talk about the concept of partnering with these communities. What are models, and this is a question for everybody, of those type of collaborations? Collaboration is a big theme. It also doesn't have one size fits all. what are those successful partnerships or collaborations, if it's with patient communities, if it's with doctor communities? What do those look like? What are the underlying points of success?
Can I give you an example?
Sure.
So we have been partnering with the industry where they provide us with early protocol, and we ask the community, the members of the communities, to look into the protocol and make comments. And it's very easy to improve protocols in this way, because protocols are designed in a very scientific way, and the scientific way is very good for science, but sometimes it forgets about some really human aspects that are going to block most patients from being able to participate.
In ECHO, ECHO is fundamentally a network of collaboration. The role of technology is just singular, to reduce the transaction cost of collaboration. But fundamentally, ECHO is about task shifting, trying to make every human being work at the highest level of his human potential. And that requires three things in our view: interprofessional consultation and help, mentor-mentee relationships, and guided practice. If you do this, any human being can scale up their expertise to be a higher performer. In the field of cancer, in order to get really world-class outcomes, you need a lot of task shifting to occur. And what I mean by that is, a patient comes and gets his breast cancer treated in Boston but goes back. The issue is, who is going to be doing the survivorship care? What is the role of the nurse? What is the role of the community health worker? If you want to prevent lung cancer, who is going to teach the primary care clinician, the patient, about smoking cessation and best practice? It's not going to be the doctor. What community health workers will you train? How will these people, if you want to set up screening programs for early diagnosis of breast cancer, cervical cancer, colon cancer, lung cancer, who is going to educate this person on what is the right screening test for this person? What are the hazards of this risk? It's not going to be a doctor, I promise you. It's not going to be a doctor. It's going to be somebody else in that system. So we have to build these collaborative teams in the local area where patients live, each part of that team empowered with the knowledge they need, some to be patient education and support workers, some to make the decision on what test has to be ordered and ordered it, some to track the results to make sure the patients get the results and be educated on the consequence of that. And all of this has to come together, and our knowledge networks are designed for that, to promote this collaboration at low cost. Because otherwise, anybody can do it if we travel to every rural area and help them, but it would cost 100 times more. And so that's the idea.
I think that there's a principle there that's important that carries through in a lot of different ways, and that is, when you're looking to change behaviors on a broad scale, the way to start that is almost never to start with addressing people or organizations that are doing the opposite of the desired behavior and trying to get them to change. The much more likely way to succeed is to find examples where those behaviors are already being exhibited, even if it's in non-traditional places, and to lift those up, to give people an opportunity to step out of a normal role. So just as an example, I think we've seen healthcare companies for a long time, maybe for the last 5 or 6 years, convene groups of patients, do a patient summit to learn from the patient experience. And I think that's a good and relevant practice. Every once in a while, we see that happening with a group of physicians, although in many ways, I'm not sure it's always with the right physicians, because it's usually with the docs who have the highest academic standards and the highest, I don't even know. They're really strong key opinion leaders and speak at the right conferences and publish the right research, but they're not necessarily the ones that are actually engaging with the patients on a regular basis. And so we find ourselves encouraging our clients to maybe think about engaging with a different group of physicians. A group of physicians that actually are actively engaged in an ongoing, empowered learning process with their patients. Because if you're able to learn from the interaction the best results, and I think you guys would agree with this, the best results are happening when doctors and patients are partnered in care together. They are both empowered with strong knowledge and a lot of transparency about what's happening with the patient. If we're able to find those and lift them up and have those be the folks that we start inviting in to learn from, to be a part of our summits or our advisory boards, that's the kind of collaboration that we're hoping to foster more and more.
So the red dot has been beeping at me here for a little bit, but I do want to take a question. Hopefully that we can have time at least for one question that's been on the board here, and then we can go ahead and end. The question here is, how are such sites vetted or curated to avoid inaccurate information from being shared? Does anybody want to take a brief shot at that question?
We know that about 80% of what is published in peer-reviewed publication will end up being inaccurate. So whenever I see a question like this, I'll put everything in a balance. I think that properly run online communities are among the least biased form of peer publication. And you are dealing with people that have one goal, which is to survive. They learn pretty fast that if you want to survive, you better look into science-based treatments and reject anything that cannot be considered to be science-based. And almost all the people that are members of those communities went to college. Many of them have graduate degrees. And to think that those people are not able, because they don't have a medical degree, are not able to properly assess what is published, I think is ridiculous.
With that, I want to thank our panel for interesting insights here. And the one term of takeaway is the patients being the most underutilized source of knowledge around health. And that's a very valuable takeaway. So thank you very much, panelists, for your insights.